Yes.
Hello, Sandil sir. Hello, Sandil sir.
Yes, sir. Yes, sir.
I think we can start, sir.
Hello, sir.
Joseph, sir, you can start.
Sir.
Yeah.
Okay, sir.
That one you can start.
Okay. Very good evening, everyone participating in this webinar. I, Dr. Cadwell Jobu, Associate Professor, here to host today's section. It is my great pleasure to welcome our MD, Engineer Siva Subramaniam sir, our Principal Dr. Savudala ma'am, Trustee Member Mrs. Padmavati ma'am, Dr. Karthika ma'am, our dear Vice Principal Dr. Brito Wilberdas sir, all staffs, and lastly the star of the section, our students and interns. I welcome you all to this wonderful program. Anything which commences with prayer won't be in vain. Let us all say a small silent prayer. Thank you. Today we are all about to experience a wonderful section on clinical approach to pediatric respiratory disorder. Dear audience, I assure you that this program will be full of knowledge and will be helpful for each and everyone. Without taking much time, I feel honored to introduce the special presenters of the day, Dr. M.Manoj sir and Dr. Rajendra Prasad sir. First section is taken by Dr. Manoj sir and second section by Dr. Rajendra Prasad sir. About Dr. M.Manoj sir, has completed his MBBS at Government Chengalpattu Medical College, DCH at Institute of Child Health, Egmore, and DNB Pediatrics at KKCTA, Chennai. Presently, he is working as a senior resident of pediatrician, Stanley Government Medical College, Chennai. Because of management and Department of Practice of Medicine, I welcome and thank him for taking time out of his busy schedule. The presence of such a personality in this webinar, we hope our students are able to seek guidance and gain knowledge from him. He is here to deal with a topic, pediatric history taking and examination and clinical approach to pediatric respiratory disease. Without much delay, I am handing over the section to Dr. M.Manoj sir. Sir, please. Sir, it's not audible. Hello.
Hello. Am I audible now, sir?
Yeah, now it's audible, sir.
Good evening to one and all. Thank you very much, Dr. Jobu sir, for your kind introduction. So first, I would like to thank Principal of Venkateswara Homoeopathic Medical College and all the faculties and the Department of Practice of Medicine for giving me this opportunity to share with you all whatever I have done little bit in pediatrics. So I hope this will be useful for the students, DHMS students and other members, and hope it will be an enjoyable moment. So directly we'll start with the session. So I have planned it like the first session will be history taking and clinical examination. So how do you go about it in pediatrics? And the second session will be an approach to common respiratory disorders. And in the at the final end, we'll share a few knowledge about the current COVID scenario in pediatrics. So let us first start with history taking and clinical examination. So this is my institutes where I learned pediatrics from the basics. The first one is the Institute of Child Health, Egmore, Chennai, and the second picture is KKCTH or Child Trust Hospital at Nungambakkam. So both are primary institutes where they deal with pediatric pathologies and they give a very good outcome. And the pointer. Sir, 1 second, sir. I think the PPT is not visible. Is the PPT
Yeah, now it is with.
Okay, yeah. So these two premier institutes actually they taught me a lot about practice of pediatrics. So I'll just share you whatever I've learned from them. So children basically they are very lovely to deal with. They are very much different from our adult counterparts. They usually share their happiness. It's very infectious from them, and it is very lovely to treat these children with due care and empathy. So what is required out of a good student in pediatrics for the practice of pediatrics? A student, medical student should be a good observer and he should be social and confident. He should be a good listener, dedicated and empathetic from the patient's point of view. So because once a child enters into the office practice or in the hospital setting, we should start observing the child. Each and every movement of the child, right from the entry, the gait, the laugh. From the gait, you can note the cerebellar involvement. From the laugh, you can observe the seventh wave nerve palsy. And from the, if you just give a handshake to the child, so you will know whether there is any weakness to the child. And you have to see the respiratory distress. And all these things will be coming by regular practice. And this is the requirement of the good observation power in pediatrician. So one who observes well will be making a good diagnosis in pediatrics. And nextly, we should be social and confident. So we are working with both the patient and the parents. So we should be dealing with the kind, empathetic heart with them. And we should always be in a jovial mood to deal with these children. Because some children might be crying, some children might be very much cranky, some parents might be in a very much distressing mood. So we should deal with them with a smiling face. Only then we can create a very good rapport. So the first thing is you have to create a rapport. You should not start directly with ECG or examination. First try to give a handshake, high five or a smile to the child so that you get the rapport of the child. Only then the child will cooperate with us. It's not like an adult practice where we can directly go into the examination. So you have to create a good rapport between the child and also to the parents. And it is better always you call the child by the name. The child likes it actually. So rather than calling the child by saying child or a kid, they actually love to be called by their name. For example, Ramu or Somu or Kritika, whatever the name is. So it's better to call and remember the child's name at every visitor. And basically we should be a very good listener because most of the mothers who bring the child, they have a lot of problems with them. And even though our practice might be a little bit busy, it is actually absolutely necessary that we should be able to listen to whatever the problem the mother is saying. Because most of the time, whatever the mother says might be exactly important. Because the mother is a very good caretaker. She is the one who is going to see 24/7 the child. And we doctors actually will see the child only for a few minutes. But the mother is observing the child for about 24/7 round the clock. And so she definitely comes out with the diagnosis if we give a very good listening to the mother, whatever she says. So that is very, very important. And we should be dedicated, as I have already told. So we should be able to deal with the cranky children. And we should be empathetic. That means we should go to the level of the child to know or understand the problems that the child is facing. And breaking a bad news is again very big issue. Like for example, the child might be suffering from a juvenile idiopathic arthritis, or the child might be suffering from probably a terrible cancer. So you should be able to deal with those situations with a great empathy in them. And so pediatrics is actually different from the adults. So you cannot fit a small child into a large boots or a large child into a small boot. So it's like that. So pediatrics actually is very different in every manner from the adult patients. So again, like a newborn is different from a young infant, and young infant is different from an older child, and older child is again different from an adolescent. So everyone needs a different kind of management, and the pathologies also get different. So each phase will be having certain pathologies which are very much characteristic to them. So what are the basic differences between an adult and a pediatric patient? So basically there are a lot of differences. So for example, right from the anatomy, these children actually they have their airway is very much compromisable. So once the child upper airway is obstructed, the total airway is always gone. So you should be very careful with that. So you have to deal with the children carefully. And physiology and biochemistry, their needs, the requirement, the calorie intake for children will be always calculated based on their body surface area and body weight. For example, it will be for the first 10 kg, it might be 100 kilocalories per kg. So here the weight of the child is very, very important to calculate the energy requirement. So the energy requirement it is individually decided. And also the metabolism, because basically the metabolism depends on the child's pathology. So every child will have each metabolic rate. So that is very much different from the adults. And immunologically, the children are actually more susceptible to infections. So they are more prone for infections compared to the adult patients. And the pattern of diseases also vary. For example, a same child who is presenting with respiratory distress, if it's going to be a newborn, we are going to think of transient tachypnea of newborn, or a respiratory distress syndrome, or a meconium aspiration syndrome. Whereas when the child presents with respiratory distress in about 1 year of age, then you think of bronchiolitis. If the child is going to present at about 2 to 3 years, you think of pneumonia. When the child is presenting with effortless tachypnea in an older child, you think of diabetic ketoacidosis. So the same respiratory distress, when it is presenting in different age groups, we think of different possibilities. And again, the clinical manifestations also differ based on the age groups. So, we have to make a clear-cut diagnosis, we have to plan the management, and we have to counsel them regarding the prognosis and the prevention part of the disease. So, history taking actually makes a major chunk. If you make a good history, then you carve out a good skull from your rock. So, actually, like you can see in this picture, he is making the statue of Thiruvalluvar. So, actually, like that, the main chunk is lying in the history taking on pediatrics. Only then comes your examination, and at last only comes your lab investigations and other factors. So, history taking decides your diagnosis. So, this is what I already told. A smart mother makes often a better diagnosis than a poor doctor. So most of the time you try to get open-ended questions rather than a closed-ended questions. You ask questions so that the answer should be from the mother. It should not be in a yes or no pattern. For example, how long your child has been having fever is your open-ended question. And it should not be like, has your child been having fever only for the past 2 days? The mother will then say only yes or no. So it should always be an open-ended question to make more accurate information. So coming to the history per se, so first the name, age and sex of the child is very, very important for the identification purpose, and also for example certain diseases are common in some religions. For example, the thalassemia and all is common in Rajasthan and other hilly areas, whereas some disorders are common in some localities. So their phase of residence is important, age of the child is important, and sex is also important. For example, hemophilia is going to be present only in a male child. So whenever you have a bleeding disorder and it's going to be a male child, you think of hemophilia. Whereas if it's going to be a girl child with the bleeding disorder, then you think of Glanzmann thrombocythemia or a von Willebrand disease and other diseases causing bleeding manifestations. So name, age, sex is very, very important. Then their place of residence, this I have already told, and the reliability of the informant. So usually it's going to be a mother who is going to give a history, but sometimes it might be a grandfather, grandmother, or it might be a caretaker. So you should always know who is giving the history of the child, and you should be confirmed with them whether they are the caretaker for quite a long time. Because if they're going to take care only for 1 day, they're going to bring the child, then they may not give a very reliable history. So this is very important. And always when you're taking history, then you should note down the complaints in the chronological order. So that means the first symptom should be written as should come first. Then you should ask the latest symptom. So the first symptom first and the last symptom at the last. So that is very, very important to know the pathway how the symptoms are evolving. And the history of present illness, actually you should take it in the patient's own words. So you should ask the positive history, corresponding negative history you should ask, but everything you try to make it in the patient's own words. And past history actually is very, very important because this might not be the first time the child is having a respiratory distress or an edema or a child weakness. This might be a recurring problem. So you should always ask whether there has been a similar problem in the past in this side. And antenatal history is very much specific in pediatrics because in adults we don't concentrate on antenatal history because in a pediatric patient's life actually starts right from in utero. It starts. So the factors which affect the in utero period, that is your infections, for example your rubella, they might cause a congenital rubella syndrome and the child might land up in a PDA, and then it might be a drug intake. The mother might have taken anti-epileptic drug, so the child can have a fetal height joint syndrome. Or there might be an increased irradiation, or there can be complications of pregnancy. For example, the mother might be a diabetic on insulin during the pregnancy, so that would cause an effect on the heart. For example, a congenital heart disease is very, very common in infant of diabetic mother. Or it can be a simple iron and folic acid supplementation. When they don't take iron and folic acid supplementation, they might land up in neural tube defects, that is the meningocele and meningomyelocele. And immunization in the antenatal period, for example, tetanus TT injection is very important so that neonatal tetanus can be prevented. And coming to the birth and neonatal history, this is also very important because most of the times a child who is coming to a clinic with a developmental delay, for example, the cause being a birth asphyxia, then the history of neonatal period is very, very important because the place of delivery, whether it was cesarean or an normal delivery, and how was the ABGAS score of the baby, whether the baby required any resuscitation, whether the baby had suffered a significant hypoxic injury. So that is very, very important in the children with cerebral palsy. So that is very important to be asked. And also history of sepsis, jaundice and other problems in newborn period is important because they would have undergone an exchange transmission, or the baby would have been having infection in the newborn period. So that would cause a long-term problem in these babies. So all these things should have been asked to get a comprehensive history. And another core problem in pediatrics is the developmental delay. So for example, when a child is presenting to us with the development delay, we should be able to ask each domain separately. So we have several domains like your gross motor, fine motor, social, language, hearing, sleep and bladder and bowel habits. For example, gross motor, the child should have attained the head control by about 3 months of age, and the child should have sat with support by 5 months, without support by 8 months, standing by 1 year, and the child should have started walking at least by 15 to 18 months, and the child should have started running by 18 months. And fine motor, the child should be having a bidextrous grasp by about 6 months, and a palmar grasp by around 9 months, and a pincer grasp by 10 to 11 months. Then the child should be able to arrange blocks, so that should also be possible for the child. And coming to social history, you have to ask me when the child started having a social smile. So usually the children smile at the mother's face by around 3 months of age. Then they start playing with the mirror image, that by around 6 months of age. And they can say tata bye bye by around 9 months of age. Then stranger anxiety will occur by around 1 year of age. So all these are social part of social domain in your development. And language, they start speaking monosyllables by around 6 months, 9 months they start bisyllable. By 1 year they should be able to say at least 1 to 2 words they should be able to say. And bladder control they should have achieved by around 3 years for the day diuresis should have stopped. And by around 4 years they should be able to hold their bladder during night times. So all these are very much important to know exactly at what point the child is lagging and which stage the child is lagging, so that you can make a good diagnosis of the problem and also the pathology. So next is the dietary history. So coming to the dietary history, actually you should have concentrated mainly on the breastfeeding, because breastfeeding is the most important nutrition for the child in the pediatric age and also for a long-term immunity in the adult. So breastfeeding is actually recommended for about 6 months exclusively and till 2 years if possible. And you should also ask about the weaning history or your complement repeats, when they were started and how much they have given complement repeats. Because whenever a child is presenting with poor weight gain, a failure to stay child, then actually these dietary pattern is very, very important. 24-hour dietary records. So you should ask the parents what the child has been taking on a 24-hour basis. Whatever the child has been taking, you should ask them, so that the mother will recall and tell you, and you calculate the calorie and protein that the child is taking, so that you can know the deficit that the child is having. And you also ask about a food allergy or intolerance, because that is very important when the child is going to present with some edema, angioedema, or the child might present with some rashes. So it's very, very important. And immunization history, according to the national immunization schedule, whether they have followed and taken the corresponding immunization, because when they have missed out any immunization, then probably they may land up with the corresponding infections. And history of contact with tuberculosis is also very, very important. So whenever a child is having contact with a known open case of tuberculosis within the period of 2 years, then it is very, very significant. Then you should think of tuberculosis, provided the symptoms of tuberculosis is present in an Indian setup. So next is your family and socio-economic history. So consanguinity, that means marriages that have been made within relations. For example, first degree consanguinity is within brothers and sisters. Second degree consanguinity is between a maternal uncle and a daughter. So, and third degree consanguinity is between a cousins, and a fourth degree is the far away distant relative. So that is very, very important to know the pattern of inheritance. For example, an autosomal recessive, autosomal dominant, X-linked dominant, and your Y-linked diseases. So they will follow certain pattern, which is very common in close, that is your first degree and second degree marriages. They are very, very common. So you should always ask about the degree of consanguinity. So you should put a pedigree chart for that. And the literacy rate, because you should be able to counsel the parents and they should be able to understand the problem. So that you should always ask about what is their literacy rate, so that you can counsel accordingly. And socioeconomic status to evaluate their sustainability for the treatment part of the disease and for the investigations. So once you get to the history taking, almost it should be able to come to a provisional diagnosis. Then from the general examination, we should be able to make a good diagnosis. So we'll see what are the things we should be seeing in a general examination. So first and foremost, the position of the site. So here in this picture, actually you can see a child who is lying on the lap of the mother. So whenever this child is there, you should be seeing that the child is very much sleepy, drowsy, and you can see the respiratory distress in this child. So the position of the child is very, very important. And whenever the child is coming with the respiratory distress, try to keep the child on the mother's lap, because that is the most comfortable position of the child, rather than making the child to lie down. And coming to the general appearance of the child, we should be able to tell whether the child is going to be ill-appearing or a well-appearing child. If the child is going to be very much thin-built, then you should think of a long-term malnutrition of the child. And the level of consciousness of the child. Level of consciousness to the child, actually it is very, very important, because the child might be in an alert state, the child might be in a verbal state, the child might be in a pain responsive or unresponsive child. So because you should not keep a unresponsive or a pain responsive child in your clinic, you should send them for an emergency management. So you should see the level of consciousness of the child. Then you have to see the attitude of the child, and posture of the child is very important. Then you go to the pickle. Pickle means you look for pallor, that is anemia, in the conjunctiva of the child. Either in your palpebral conjunctiva or in the hands, you look for anemia. You look for icterus in your bulbar conjunctiva. You look for cyanosis and clubbing in your hands, and in cyanosis in your lips for a central cyanosis. And you look for generalized lymphadenopathy, and if at all any edema is present. So these things are a part of your general examination. Then comes your vital signs. You should not miss the vital signs, because they are going to be very much important to know whether the child is sick or not. So you check the temperature by your thermometer, and then you use your BP apparatus to check the blood pressure. And it is best to check the upper limb BP and the lower limb BP. And also pulse, when you see it, you see the radial pulse, and also in lower limb you see dorsalis pedis, that is between your, it's not visible here, so actually you see between your first and second metatarsal bone, the foot, so that you will have an idea whether the lower limb pulse is also well fed. So because, for example, a coarctation of iota child might not be having a lower limb pulse that is palpable, and also in, for example, in blood pressure, actually the lower limb blood pressure might be very much less reduced in your coarctation of iota. And whenever you see your respiration, you have to count it for 1 full minute. Only then you will be able to know whether the child is having a fast breathing or not. Then coming to the anthropometry, you have to measure your length, weight, height, head circumference, mid-arm circumference, and other things. So the first is one person showing the measurement of your head circumference. So this is how you measure the head circumference. For example, in this side, actually it's very much appreciable. The child's head circumference is very much large, increased. So it's obviously a child with macrocephaly with probably a hydrocephalus. That is the retention of your CSF within the ventricles. And this child is a cerebral palsy child having a small head. So this is a microcephaly. So this is an example for microcephaly. So this can be noted by your measurement of head circumference. And this is how you measure your height and your length. So what is the difference between height and length is when the child stands up, that is more than 2 years child can be able to make to stand, and you measure the height. For example, in this Frankfurt plane. But by the same time, when the child is not able to stand, less than 2 years child, you have to make the child lie down, and you have to use an infantometer to measure the length of the child. So that is very important. And after this general examination, vitals, and then your anthropometry, you go to your head to foot examination. So from the head to the foot, you have to observe whatever abnormalities the child is having. So we are just showing few pictures to know. For example, this first one, actually this child is having a ptosis, bilateral ptosis is there. So this child is having a congenital myasthenic syndrome where he is presenting with bilateral ptosis here. And here you can see an ash leaf macule in a child with tuberous sclerosis. And this is a very coarse species noted in a child with congenital hypothyroidism. The look itself, the face itself is very coarse. It's not in a normal texture. So that is very characteristic of your congenital hypothyroidism. And this is actually a rashes in the palms and soles, which is common in your hand, foot, and mouth disease. So once your head to foot examination is over, then you go to your systemic examination. So system-wise, you should observe. For example, if they are presenting with a cardiovascular complaint, you go start with a CVS examination. If they come with a respiratory symptom, you go to RS examination and so on. But it is not hard and fast rule that you have to follow the same pattern, because most of the time children, before they get cranky, you should be able to auscultate for your respiratory sounds and also your murmurs and other things. The examination part, for example, your knee hammer, using a knee hammer for your reflexes, that can be done last, because that will make a child to become very much cranky. So that should be taken in the last. And spine and cranium, you should not miss out, because there might be some hidden defect in your spine and also in the cranium. And last but not the least, the developmental assessment should be done. So whatever is from the history you have asked, you should be able to demonstrate in the child that the child has been suffering from so much of developmental delay, either in your language aspect or your motor or social aspect. So that should be assessed. So once you have completed all these things, you should be able to come to a final diagnosis, and then you plan your management accordingly. So this is what is your approach to your pediatric history taking and examination. So next we'll see into specific respiratory disorders. Having seen all these things, so we'll see how to diagnose or how to approach a respiratory disorder. So whenever the child presents with common respiratory problems, so we'll see how we are going to approach those children. So whenever they come with a respiratory illness, we'll see how the child is going to be approached by us, so that we don't miss out a very ominous problem and we don't take things very lightly also. So whenever few features are present, you should be always very careful in dealing with this. So cough being the most common presentation of children with respiratory illness. So first we'll start with cough. So whenever the parent comes and says my child is having cough, then there are a set of questions which we need to ask to make the diagnosis to be focused. Rather, because cough is a very big symptom that can be present in a serious RS problem, it can present in a GI problem, or it can be presenting in a cardiovascular problem. So you should be able to narrow down your diagnosis, for which you should be able to ask a certain questions to narrow down your diagnosis. So, what are the questions you should ask when a child presents with cough? You should ask the duration of cough, age of onset of cough, nature of cough, timing of cough, aggravating and relieving factors, what are the associated symptoms, and whether there is any significant family and environmental history. So we'll see each in detail. So based on the duration of cough, so for example, if the mother is saying the child has been suffering from cough for the past 1 week, then it comes under your acute cough. At the same time, when the cough duration is more than 4 weeks, it is categorized as a chronic cough. And again, in the chronic cough, you can divide them either into a recurrent pattern or a persistent pattern. That is, every day the mother will say, my child is coughing every day. Then you think of a persistent cough. The mother will say that the child has been well in between the episodes. The child had cough for 2 days, then he was normal for 1 week, then again he is having cough for next 3 days. That means it's a recurrent cough, which is the total duration is more than 4 weeks, but still the child is having a very good pattern of living in between, and then again he is having cough episodes. So that comes under recurrent cough. So because each one will be pointing towards a certain diagnosis that we will be seeing the first slides. So based on age of onset of cough, we are classifying them into a lot of diagnoses. For example, when the onset of cough is in a young infant, we will be thinking of these possibilities. And they present within 4 weeks, you think of viral infection to be the most common. So they will present as coryza, running nose, with cough and low grade fever. So you think of a viral infection. The same infant who is having recurrent vomiting or regurgitation. Whenever the mother is feeding, the child will have a regurgitation of feeds, and associatedly the child might be having cough. So then you think of a GERD, that means a gastroesophageal reflux disease. And if the mother is saying the child is continuously coughing in a young infant, then think of a congenital anomalies. For example, a tracheo-laryngo-broncho-malacia. That means the flopiness of your larynx, trachea, bronchus. So this will cause cough in the child. At every breath, the child might be having a cough. So when in a young infant, when they're presenting with acute presentation, think of a viral problem. Recurrent presentation, you think of a GERD. Persistent problem, you think of congenital anomalies. So this list is not a wholesome list, but we just see whatever is very common in children. And when in the early childhood, for example, a child who is of age 2 to 4 years or 5 years, less than 5 years child, presenting in an acute setup. Mother is saying suddenly the child was previously well child, suddenly child is having coughing. Then first thing should be thought of is your foreign body, and that too when the child is, when there are 2 siblings, a older sibling who is very very naughty, he might put some foreign body, for example a peanut or a small hard stone or something the child would have put in the younger child's mouth, so that that might be aspirated by the child into the trachea, leading on to recurrent cough in that child. So acute setting, think of foreign body aspiration. And when the child is having a recurrent cough, then you think of asthma. So we'll see in detail about asthma later. So whenever there is recurrent bouts of cough in an early childhood, you think of asthma. And persistent cough is also a retained foreign body, because the mother would have forgotten. The mother would have thought, okay, it was simple cough at the initial phase, and then they would have totally forgotten. The child would have been normal in between. Then again, when the foreign body goes and obstructs the carina, that is the junction of your left and right bronchus, then the child might become again tachypneic, breathless, and he might have a lot of cough. So then you have to think of a retained foreign body that has not been removed in a persistent cough in this children. And in an acute setting in an older child, you think of asthma. They might be having exacerbation of asthma. That is, they may present with a severe asthmatic exacerbation. They might present with a life-threatening asthma. They may present with a near-fatal asthma. So very severe respiratory distress and the child might come. So it is always asthma you have to rule out, because that is very very common in our setup. And whenever there is a recurrent cough in older children, you have to think of 2 things. One is a rhinosinusitis, allergic rhinosinusitis, and the other one is a psychogenic cough or a habit cough. So habit cough, like for example, you would have started as a viral cough, then the child would have got used to that habit of coughing, and the child would be enjoying the cough also. Actually, he would be coughing in bouts. But what is the thing to clinch the diagnosis of psychogenic cough is these cough will be disappearing totally during sleep. So that is very very important here. And a persistent cough in a oral site, you think of your bronchiectasis and your interstitial lung disease. So these are less common conditions, but still you have to think of these things when there is a persistent cough in oral children. So coming to the nature of cough. So whenever when the mother says cough, you have to ask the mother to describe how the cough pattern is, or how you are able to hear the sound of cough. For example, when the mother says he is always clearing his throat, the child is clearing his throat, then you think of postnatal drip. That is, in case of a sinusitis, rhinosinusitis, the child will be, most of the time, the phlegm will be discharging and traveling in your pharynx. The child will be swallowing it. So the child will be trying to clear the throat most often. So this is what is known as your postnatal drip in your rhinosinusitis. And the child might be having a dry irritating cough in your post-viral pharyngitis. So whenever the pharynx is inflamed, a pharyngitis is present, that is especially your viral episode, then the child will be having a irritating cough in this. And then barking cough. So barking cough, like actually it's very common in your upper airway, for example, your larynx involvement. So whenever there is a laryngitis, for example, your croup means your acute laryngotracheal bronchitis, which is caused by the organism, your viruses, commonly your para-influenza viruses or your rhinoviruses. So they affect your larynx, that is the upper part of trachea, the respiratory system. So when that is there, they will be having a barking cough. That means there will be the voice will be changed, it will become more hoarse, and it will be almost similar to a barking of a dog. And then whenever the slightly lower airway, that means your tracheitis, tracheal part of airway is involved, then you have a breathy cough. The pattern of cough will be more breathy. And in asthma and pertussis, you will be having paroxysmal, sudden onset of cough will be there. The child will be normal, then suddenly they will start coughing. And especially in pertussis, you will be having your persistent cough will be followed by a whooping nature. That will be, the child will be taking a deep breath following a paroxysmal episodes of cough. So it will be like cough, 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 then suddenly the child will be inspired. It will be taking a deep breath, then again it will be starting to cough. So that is very common in your pertussis. And staccato cough means, again it's a continuous cough pattern which is occurring in chlamydia infection. And in case of pneumonia where there is a bacterial infection or an abscess, a lung abscess, then the child will be having a wet rattling cough. That is when the mother will say, whenever I am touching a baby's chest, I am able to feel some noises in the chest. And the child will also be having a wet cough. Wet cough means the child will be able to produce a sputum. So that is what is meant by wet cough. So that is very common in your pneumonia and your suppurative lung disease. So based on the timing of cough in each day, then you can narrow down your diagnosis. For example, your early morning cough is very, very common in asthma. Why? Because the lungs total volume and the vital capacity actually reduced in your early morning, and also your cortisol levels will be at the lowest level in the early morning period. So this cough of asthma is very, very common in early morning period. And the first few minutes after waking up. So because of the lying down posture, these secretions would have got accumulated in your parenchyma, that is your alveoli, and once the child gets and starts to walk, then the child will be having coughing, because they would go to your airways. So they will stimulate the cough receptors in your airways. So they have cough. So what you have to remember is, the cough is more in your upper airway and your airway problems. Cough is less in your parenchymal problem, because the cough receptors are more in your upper airway and the airways. That is your larynx, your trachea, and then your bronchi. Whereas the cough receptors are not much present in your lower part of your respiratory system. That is your alveoli, interstitium, the pleura, and all these things are not innervated by your cough receptor. So whenever there is pneumonia or pleural effusion, cough is actually less likely. Okay, so that we should remember. And worsening in the evening setup, for example, in a city like Chennai, where the pollution is more, in the morning period the sky would be very much clear, and as the day goes on, the pollution increases, and so there is a worsening of cough in the evening period. And worst cough in the night, you think of postnasal drip. So once the child tries to lie down in the reclining position, then the child will be having a dripping of your secretions into the pharynx, and again the pharynx, the cough receptors are present, so the child will be having recurrent cough in the night, especially on lying down. And after feeds, this I have already told, GERD is very common after lying down in a young infant. See why GER is very common in young infants, because most of the time the angle of his is not very much well developed. That is, the junction between your esophagus and your lung, the esophagus and your stomach, the angle is very much obtuse in these children. So the chance of reflex is very common in these young infants. And the lower esophageal sphincter is also not well developed in young infants than newborn babies. So they have a much tendency to reflex whatever content is from their stomach into your esophagus, and again leading on to spillage into your respiratory pathway. So that is why GER is common in newborns and young infants. And soon after exercise. Actually, this is very, very characteristic in asthma. So asthmatic child might be asymptomatic in the normal position, and you want to know whether the child is asthmatic or not. What you have to ask is, you have to ask the child to go have a jogging or running in your clinic or your hospital. Then you have to assess the child again. The child will start having wheezing and breathlessness. So that is what is meant by your aggravation with the exercise. And then psychogenic cough, this I have already told. So they will try to have the attention of the parents and other caretakers. So the child will start having cough episodes recurrently, but these children will be normal during sleep. So you can see the difference. An asthmatic cough will be persistently present during sleep, whereas in your psychogenic cough, it's totally absent in the sleep. Only in the wakefulness, the cough is present. So you think of a habit cough or your psychogenic cough. So we'll see about the aggravating factors. For example, in asthma, your dust, aero allergens, your the pest allergens, the smoke, exercise, all these are the trigger factors for your asthma. And in psychogenic cough, whenever the patient, whenever a caretaker or they're in a public place, and also when they're in a stressful situation, the cough tends to be increased in them. And relieving factor, for example, in asthma, you treat them with a bronchodilator therapy, then they respond very well, and the child gets better. So that again, it's a retrospective diagnosis of asthma. And family history and environmental history is very, very important in this cough. So whenever there is a family history of atopy, that means their tendency to be allergic. They might have atopic dermatitis, they might be having, father or mother might be having your allergic rhinitis or dermatitis, or issue of again asthma itself. So it's very, very significant in them. So the child might be having a more chance of getting the asthma and allergic rhinitis from them. And history of contact with TB that I have already told. And history of allergy towards food allergy. That means the child might be allergic towards your peanuts, or the child might be allergic to some contact dresses. So you have to avoid those things in these children. So exposure to passive smoking. So children are very much susceptible to passive smoking. So father might be a smoker. The child will be having a passive smoking exposure, which might aggravate your asthma in this children. So, and then you have to look into what are the associated symptoms to the cough. So apart from cough, what are the other features that are present that will narrow down our diagnosis? For example, the presence of noisy breathing. For example, the snoring, stridor, wheezing. These will point towards certain pathologies, which we'll see in the further slide. And associated with fever or not, whether the child is having breathlessness or not. So this will narrow down our diagnosis. So whenever the mother is saying, I'm able to hear some abnormal noises, then you have to ask a few questions. Whether the noise is present constantly, or whether it's present only during inspiration or expiration, and whether it's present in both inspiration and expiration, or whether it's going to be changed by any position, or it's getting aggravated or it's getting disappeared during sleep. This we have to ask. So we'll see how it varies. So whenever there is a snoring, the mother is saying snoring, or you observe a snore in the child, then the point of origin is your oropharyngeal region. So your oropharynx is the main area where they start snoring. So that can occur in both during your inspiration and expiration. So snoring is present both in your inspiration and expiration. The problem is in your oropharyngeal airway. So for example, your adenotonsillitis, or you have your pharyngitis, or you have some mass in your throat, retropharyngeal abscess, or your parapharyngeal abscess. So in such cases, you will be having a snoring. Obstructive sleep apnea syndrome might be present. So whenever a snuffle is present, that is whenever they have discharge from their nose, the mother will say, always my child is sniffing, that is the snuffle is there. So that means the problem is your nasal passages. It might be a simple URI, with a viral URI or an allergic respiratory problem, where there is blockage of the nose causing the snuffle sound. The child might be always snuffling. It is present during your inspiration and expiration. And whenever there is a stridor, so stridor is actually a very harsh sound. You'll be able to hear like the child making a loud sound during, especially in your inspiration. So whenever a stridor is present, you think of your extrathoracic area, that is in this segment, the upper airway, your larynx, and then your upper trachea, you think of stridor. So upper airway problem, you are involving your larynx and your upper trachea, you think of this stridor. Whenever stridor is present, you think of this problem. And rattling, so whenever the mother says, I'm able to feel some noisy movements in your chest, then you think of your intrathoracic or extrathoracic airway problem. For example, your bronchitis, or again in your asthma also, your rattling might be present. And whenever the mother says she is able to hear a very good wheeze outside, it's definitely an intrathoracic airway problem. For example, a lower airway, that is your bronchial problem. So there will be hyperinflammation of your bronchus, narrowing of the bronchus, leading on to your wheezing problem, which usually presents during your expiration. So wheezing sound is usually heard in your expiration. And grunting is another sound which is actually heard in your expiration in a very sick child. For example, a pneumonia or a young, in a child with pulmonary edema, the child will try to grunt. That is, with a closed airway, the child will be trying to breathe out to open up the alveoli. To increase the pressure here, the child will be trying to breathe out by making a sound like this. So this is your grunting, which is common in your pneumonia and your pulmonary edema. So whenever these added sounds are present, you localize the problem to these pathways. And this is again the example. For example, whenever the stridor is present, you think of your ALTB. I've already told group. ALTB is acute laryngotracheal bronchitis or a group. And when it is persistently present, you think of your laryngomalacia or upper airway floppiness. The larynx might be very floppy in this children. And whenever the child is having wheeze, you think of a lower airway problem. Either your viral associated wheeze or your asthma in this children. Or a young child, you think of bronchitis. That is your first episode of wheeze. In a young child, you think of bronchitis, which is caused commonly by your respiratory syncytial virus. When it is persistently present, wheezing is persistently present, then you think of tracheobronchomalacia again. That is below the larynx, you are thinking of tracheobronchomalacia, or it can be a persistent asthma. And whenever there is a grunting, you think of serious condition like your pneumonia or your hyaline membrane disease in a newborn, or it can be a COPD in a older adolescent child. And already I told snoring, it could be due to because of your adenotonsillitis or your obstructive sleep apnea and hypopnea syndrome. And rattling, it can be because of your viral bronchitis, or in certain cases of neuromuscular disorders also, because of the retained secretions, the child might be having your rattling sound. That is, your mother might say, I'm able to feel sounds in the chest. And snuffling, it's just because of a simple running nose or nasal block, which can be either an allergic cause or because of a viral URI, the child might be having snuffle sounds. So here we have a flow chart like how to approach whenever a child is having a acute stridor. Whenever there is a stridor sound and there is a suprasternal retraction. So this you can see in this picture. You can observe your suprasternal retraction. The child is actually pain responsive child is sick. You are able to see, you are able to see the retractions here. You can able to see your subcostal retractions here. You can see your suprasternal retractions here. So this is actually a very sick child who is on oxygen therapy. So in acute setting, when a child is presenting with stridor, you should not miss these few emergencies, medical emergencies. So what are they? So it is very rare disease, but definitely you should think of epiglottitis. Epiglottitis is your inflammation of your epiglottis, which is caused by H influenza B bacteria, which will cause acute obstruction to the airway, and the child will suddenly collapse in front of your eyes. So always you should be very careful in your office practice or a clinic practice. So whenever you feel the child is having sudden onset of stridor means it will be like this, like this. The child will be having sounds. So when you hear such sounds, you think the child is very sick, and you try to make hospital admission for this child, provided the child is not sick on your total examination. Okay. So you think of epiglottitis, foreign body aspiration, and angioneurotic edema. That is, all your airways get inflamed, and the child might be because of your allergy, and the child will be not be able to take air into his lower airways. And whenever the stridor is not associated with fever or no history of any upper respiratory tract infection, then you think of hypocalcemia. That might also cause your collapse of your airway, resulting in your stridor. Or when there is a low grade fever with a mild URI symptoms, your coryza, you think of ALTB or your flu. And whenever there is high grade fever, you think of epiglottitis and diphtheria. That is very, very dangerous. You'll be able to see patches in your oral cavity examination. You'll be able to see your membrane in your pharynx and over your tonsils. And quinsy is your peritonsillar abscess, then your parapharyngeal abscess, retropharyngeal abscess, and bacterial tracheitis. So these are all very, very sick children. When they present with if you suspect these things, so you should ask them to get admitted and get treatment, because otherwise the child may become very much sick with short period of time. So whenever a child is presenting with wheeze, we should be clear that wheeze is actually a high pitch sound and it is a whistling like sound. So they will be able to hear wheeze without even a stethoscope, or sometimes you need a stethoscope to auscultate a wheeze. So we should remember that all wheezes are not asthmatics, because asthma might be present even without wheeze. For example, a cough variant asthma, they might present even without wheeze, they will be presenting only with cough. Or children might also present with a crepitations, fine crepitations, an asthmatic child. Or in case of a life-threatening asthma, it will be called as a silent chest. So that means the child will not have any added sounds. The child, when you oscillate the chest, you will not be able to hear any added sounds. Okay, so the child might be sick, but still the chest might be very much silent. So that is also possible in asthma. So you don't think that all wheezes are asthmatic, and also don't think that asthma will present always with wheeze. So whenever a child is presenting, young child is presenting with wheeze, you think of all these possibilities: a bronchiolitis, or a viral wheezer, or a multi-trigger wheezer, or an atypical wheezer. So what is all this? So in a young child around 6 months to 2 years of age, presenting for the first time with wheeze, with a prodrome with low grade fever and a mild rhinorrhea, you think of bronchiolitis caused by a respiratory syncytial virus. And again, when it is episodic wheeze, that my mother might be saying, this is the third time the child is having wheeze with breathlessness, and every time the child starts with a low grade fever, the cough lasts for about 3 to 4 days, then the child improves, then you think, and the child is well in between episodes, then you think of episodic wheeze. So every time it starts with a URI, then it spreads to the lower respiratory passages and presenting with wheezes. Then you call it as an episodic wheezer. Or it can be a multi-trigger wheezer. So whenever there is a atopy in the child, either in the child or in the parent, then you think of multi-trigger wheeze. So here also the child will be having multiple episodes. For example, it may be triggered by your cold exposure, your pet in the house for your dog, cat, or pollution exposure might trigger them. So usually there will be afebrile. So because that is not going to cause fever in them. And the child will even be symptomatic between episodes. For example, whenever the child is having physical education class, for example, a PD class, the child will be running, and again the child will start having breathlessness. Even at the normal days, even without cough, the child will be having breathlessness, which may be provoked by your exercise. So then you think of your asthma. So this is where all the characteristic features of asthma. This you should remember always. So whenever there is a recurrent wheeze, recurrent isolated cough, recurrent breathlessness, nocturnal cough, tightness of chest, and exercise or a trigger-induced symptom, then the first possibility should be your asthma in children. And these symptoms usually will be afebrile episodes, and there will be a personal atopy. That is, the child will be having skin rashes will be there, or child might be having your allergic rhinitis. So there will be allergic shyness here. There will be your dark circles around your eyes. These are pointers for your allergic rhinitis. So that is usually we call like brothers and sisters. So whenever a child is having allergic rhinitis, they are more prone to have asthma. Okay, so they are like brothers and sisters and a sibling. And seasonality. So these asthma episodes are very common in your cold exposure, that is winter season or your rainy season, and they respond very well to your bronchodilator therapy. So what are atypical wheeze? So the first 3 things we saw were typical towards certain markers. So these wheezers, now what we are going to see now, there is going to be some other diagnosis. It's very rare, or you should always keep it in your back of your mind. You should not be missing them, but you should always suspect in the second line. So what are these causes? For example, a child who is having a recurrent vomiting or recurrent aspiration, then you think of your gastroesophageal reflux disease. And also the child might be having a congenital heart disease. So the child might be having a left right shunt. That means the acyanotic heart disease, your ASD, VSD, then your that is your ventricular septal defect, atrial septal defect, your patent ductus arteriosus. The child will be presenting with cardiac failure. The lungs will all be filled with fluids. Your pulmonary edema will be there. The child will be presenting with breathlessness and wheezing. And so you should think of a congenital heart disease in this children. And whenever there is a persistent symptoms, for example, a rhinosinusitis might present with a persistent post-natal discharge, or there may be persistent headache, persistent discharge will be there from your nose beyond 2 weeks of duration. Then you think of rhinosinusitis. And again, whenever there is a contact history of tuberculosis, or the child is having a persistent lymphadenopathy, persistent cough more beyond 3 weeks, you should also think of tuberculosis in our Indian setup. So these are all very rare conditions which might also present with the wheeze in these children. So though they are rare, we should always also have them in our mind. For example, a immunodeficiency. So recurrent infections, bacterial infection might cause them to present as recurrent pneumonia in these children. For example, A-beta immunodeficiency, for example, the child might be having a hypogammaglobulinemia. Okay, so the child will be having immunoglobulin deficiency. The child will be having recurrent infections, and the child might be having a ciliary dyskinesia. That means your hair cells will not be functioning properly. So they will be having recurrent respiratory tract infections, clubbing, dextrocardia, situs inversus. That means the rotation of your heart and other internal organs will be rotated to the opposite side. So you think of your ciliary dyskinesia. So that for your examination, you'll be able to find that your liver is not palpable on your right side. Liver might be palpable on the left side, and your auscultation, you will not be able to hear your heart sounds in your apex. You'll be able to hear your heart sounds more on your right side thorax. So you think of your ciliary dyskinesia. Or the child might be having a failure to breathe. The child will be very thin, lean child with malabsorption, fatty stools, recurrent respiratory infections, and consanguinity. Because it's an autosomal recessive disorder, it usually occurs in marriages within families. So you think of your cystic fibrosis. Or whenever it's an acute setting, the first episode, you think of very emergency conditions like a foreign body aspiration. So in foreign body aspiration, so mother will say sudden choking, localized wheeze and auscultation will be able to hear, and the air entry will be decreased. Actually, you will be able to hear air entry on one side, whereas whenever the foreign body is obstructing the right, for example, right bronchus, then you will not be having decreased air entry in your right hemithorax and your right axilla. And then the history of diet allergy is important. So because like food allergy, for example, peanut allergy is very common in abroad. So they might be presenting with angioedema and present with cough and wheeze. So based on all your history taking, you should be able to say whether there is a problem or not. And if at all there is a problem, what is the problem? And if you find out what is the problem, you have to localize where is the problem. Only then we will be able to manage the child accordingly. Because without coming to this conclusion or answer to these questions, we will not be able to give a good diagnosis and will not be able to come to a good treatment plan for them. So after getting all this history, from the examination part also, we will be able to get a certain clues for them, for our diagnosis. For example, whenever there is a clubbing in your fingers, then you think of your long-term problem. For example, your interstitial lung disease, or a suppurative lung disease. And whenever there are signs of CCS, that is, the child is tachypneic, having intercostal retractions, child is having suprasonal retractions, child is having bilateral creps and wheeze, you think of, and also there is a murmur, you think of a congenital heart disease. And whenever child is presenting with rash, fever, you think of your viral problems, either your adenovirus, or it can be your atypical organism like a chlamydia, then it can be some other respiratory infections, and even COVID actually they can present with fever, rash and cough. And lymphadenopathy is common in your tuberculosis. So chronic cough, lymphadenopathy, you think of TB at the first point. And whenever there are going to be skin rashes or eczema, flexural dermatitis or allergic shyness here, your dark circles and your mouth breathing, you think of your atopic problem, you think of your asthma and allergic rhinitis in these children. And whenever their child is going to be very thin, lean, failure to thrive, you think of chronic problems like a cystic fibrosis. So always you look for the respiratory rate. You count the full respiratory rate, and you please remember that in a young infant, actually it's all age dependent, the cutoff. So in a young infant less than 2 months of age, when the respiratory rate is more than 60 per minute, then it is said to be tachypneic. And respiratory rate more than 50 per minute is tachypnea inside between 2 to 12 months of age. And when the respiratory rate is more than 40 per minute in a less than 5 years child, it's significantly tachypneic. And in the oral child, when the respiratory rate is more than 30 per minute, it's called as tachypnea. So whenever these rates, respiratory rate go beyond these cutoff, you can tell that mother that the child is very sick and the child requires hospitalization and further evaluation. So whenever you are observing a child in a respiratory system, you start observing from your upper respiratory tract to your lower respiratory tract. So you start from your ears, nose, your oral cavity, your tonsils, your pharynx, and then your whether there is any retractions here, and then you come to your auscultation and other things. Okay. So you see your chest shape, whether the chest is symmetrical or asymmetrical, because in asthma you will be having a barrel-shaped chest. Because of your persistent expiration problem, there will be air trapping in them. So they will be having a very big barrel-shaped chest. That is obviously visible in uncontrolled asthma. And again in a chronic collapsed lung, for example a post-tuberculosis collapsed lung or a foreign body leading to collapse, then there will be flattening in one side, and whereas the other side will be normal. So in between the ribs, that is the intercostal region, you will be able to appreciate the flattening. And airway obstruction, again, there will be a unilateral hyperinflation. And on percussing, you will be able to come to a conclusion whether it's going to be resonant, dull. If it's going to be dull, you think of your pleural effusion or your empyema. Or if it's going to be hyperresonant, you think of your pneumothorax. If it's going to be stony dull, you think of your pleural effusion again. So based on your percussion note, you can diagnose the problems. So again on auscultation, for example, when you have a coarse crackles, you think of bronchiectasis, fine crackles, you think of your interstitial lung disease, or whenever there is a wheezing, you see whether it's going to be a generalized wheeze or a localized wheeze. So whenever the wheeze is going to be, for example, it's going to be localized to your axilla, right side infraaxial region. It's very common site for your foreign body to be present. So you think of foreign body aspiration. But whereas the same child presenting with bilateral wheeze in all the auscultatory areas, you think of asthmatic first shot. And absent breath sounds, again, it can be either due to a foreign body, or it can be either due to a pleural effusion, pyothorax, or it can be due to a collapse lung. And consolidation, it presents with the bronchial breath sounds. That is in pneumonia, it presents with bronchial breath sounds. And murmurs will be heard in your congenital heart diseases. So once we have fully examined the child, then you make a provisional diagnosis and you investigate the child accordingly. So based on the investigations, you will be able to again narrow down your diagnosis. For example, you order the complete blood count. You see the total count in that. So whenever there is a leukocytosis, that is whenever there is an increase in the total count, for example beyond 15,000, the total count normally will be ranges between 4,000 to 11,000. So whenever the count goes beyond 15,000, then it is called as leukocytosis, which points mostly towards the bacterial infection. And whenever the eosinophil count, absolute eosinophil count goes beyond 400, or your eosinophil percentage crosses beyond 6%, then you think of your atopic problem or your asthma. And again, your Ig levels will be increased in your asthmatic children and atopic children, because that is the one which is going to be released during your inflammatory problem caused by allergy. And you do a man-2 test for ruling out tuberculosis, or sputum for acid fast display to rule out tuberculosis. And coming to a chest X-ray is very, very important. You order a chest X-ray, you should be able to read a good chest X-ray. So whenever reading a chest X-ray, you start from the, you have a certain pattern. So you start from your upper part of your GA system, that is below the diaphragm to start, whether the liver shadow is seen or not, whether the splenic flexure is seen of the colon, whether the stomach gas shadow is seen in the left side, and whether the angles are free. Both your ostophrenic angle, cardiophrenic angle should be free on both sides. Then you look at your soft tissues, your bones, your rib cage, all those things you look for any injury or any fracture or any other thing in your bony cage. Then you look into your mediastinum, your upper mediastinum and your lower mediastinum. You look for your airway. That is your trachea, the upper airway, whether it's being traceable till your carina or till your bronchus, and then you look into your heart shape, whether it's in normal shape or it's a dextrocardia or there's a cardiomegaly. You have to look into your mediastinum. Then you look into your lung fields. Whether lung fields, actually normally the lung fields will be darker than compared to your bone, because it's a radiolucent one, whereas your bone is a radiodense one. So you'll be able to see black lung fields on both sides. You should compare. First, we have to start from here, from lower side. You see within the lungs whether there is any homogeneous opacity or any alteration in the pattern of the bronchovascular markings. You have to trace it till your upper end. Then you go to the opposite side. Then again come below. Then again you compare between your right side with your left side. Right side with your left side in all the areas. Only then it's a complete interpretation of your chest X-ray. So what are the markers that you will get to know from your chest X-ray? So for example, when there is a bilateral hyperinflation, for example, this is an asthmatic side where you'll be able to see more than 8 ribs. You'll be able to see the anterior ribs will be more than 8 when you count from here. You'll be able to see in this picture. So you think of bilateral hyperinflation in your asthmatic side. And here you can see a homogeneous opacity in your right lower lobe, because the diaphragm is not very much visible, and the cardiac fill out is also not made out. So it's actually a middle lobe and your lower lobe problem. So there is a consolidation here in the right, middle and lower lobe. And steeple sign, actually it's the narrowing of your upper airway. The steeple sign is common in your acute laryngottracheobronchitis. So the upper airway gets narrowed down. So you diagnose ALTB or your tube from your X-ray. And this is thumb sign. This is because of your epiglottitis. So this is the epiglottis which has been swollen. So whenever there is a swollen epiglottis, there is always a chance that your upper airway might get obstructed and the child might become very sick. So you should be careful in making out the diagnosis of epiglottitis from your lateral view of your X-ray. So here you have a foreign body aspiration. So here you have a right lung which is normal or hyperinflated rather. You can see that the right lung is more darker compared to your left hemithorax, where there is going to be decreased intercostal space. So there is going to be collapse of the lung in your left side and the hyperinflation or emphysema, compensatory emphysema on your right side. So here the foreign body is on the left side. So there is a compensatory emphysema on your right side. So here you have a coin aspiration which is in your esophagus. So when you are able to see front and back of your coin, it's the foreign body is in esophagus. Whereas when you are able to see the side profile of the coin, then you think that the foreign body is in your trachea. Here the heart size is very much increased. So this is a cardiomegaly in a congenital heart disease. So this is a barium swallow where you can see the reflex of your stomach contents into your back into your esophagus. And tracheoesophageal fistula, you will be able to see that the spillage of your stomach content will be going into your that is your from your stomach it goes into your esophagus, then into your airways. So there will be your communication between your airway and your esophagus. So that is your tracheoesophageal fistula, which is diagnosed by your barium swallow. And other important investigation is your spirometry and your peak expiratory flow meter. So it's very important in your asthma. So you can have your systematic spirometry, which is computerized now. You will be noting your PEF values, and you will be able to make a prognostic in marker by your PEF test. That is your peak expiratory flow meters. So other rare investigations are your sweat chloride test for cystic fibrosis, and then your bronchoscopy for if you suspect a foreign body aspiration, the investigation of SARS is always your flexible bronchoscopy. And if you suspect a congenital heart disease, you do an echocardiography to diagnose a congenital heart disease. And if you think of GERD, you do a 24-hour pH monitoring. And if you are suspecting an interstitial lung disease, you do a CT test to diagnose it. So, we are almost going to come to the end of our session. So before closing, we will just see a glimpse about COVID-19 in children. So how COVID-19 is going to present in children and how children are being involved in COVID-19. So actually COVID-19 is we all know that it's a respiratory problem. So they commonly affect adults rather than children. Why? Because children actually they have less of this ACE2 receptor, angiotensin converting enzyme receptors is very much less pronounced in children. So actually this virus wants that ACE inhibitors to be ACE receptors to be present in their lung cells, that is the pneumocytes. So only when the pneumocytes have the ACE2 receptors, the virus binds to them and they have a portal of entry, they cause a severe disease. Whereas in children, because they are going to be less present, so the children are actually spared of very complicated problem. But we cannot say that children might not get a very big problem, but it's very rare in children. So how they usually present with? So most of the children, they are asymptomatic. So father and mother might be having COVID. So the child might be screened and the child would have been diagnosed with COVID problem. Otherwise, they wouldn't have any, even fever might not be present. So that is what in our hospital, actually most of the children are asymptomatic children. So some might be having low grade fever or they can have a little bit of cough. And only rarely they present with severe respiratory distress requiring mechanical ventilation. So this is the respiratory symptom. So coming to GI symptom, the child might also present with vomiting, diarrhea, with fever. So you should not think that COVID will always present only with respiratory symptoms. There are case reports saying the child might be presenting with vomiting and diarrhea, just like a viral gastroenteritis they might present, and the child might become even sick. And there are case reports that the child might be presenting with multi-system inflammatory syndrome. So what is multi-system inflammatory syndrome is that the child might present totally with your GI symptoms like your vomiting, diarrhea, and then they might present with your Kawasaki disease like presentation. That is, they might have rashes, they might have conjunctival congestion, they might have lymphadenopathy, they might be having your multi-system involvement. For example, cardiac involvement might be present. So they might present with an aneurysm, they might present with shock, like toxic shock syndrome. The child will be having circulatory problems. So all these things also can occur. There are case reports even in Chennai that these children, their children have landed up in severely sick ICU kids. They might also present with acute kidney injury, so their urea creatinine might be elevated. With the acute renal shutdown might also be there. So they can either present at a multi-organ dysfunction or as simple as asymptomatic, mild to moderate cases have been reported in children. But for our observation, for example, if we have 100 children, almost 60 to 70% children will be asymptomatic. Only 20% might be having mild symptoms, and only less than 5% children will be very sick and presenting to the ICU setup. So how do you investigate these children? So in your complete blood count, you will be having a lymphopenia. That is, your lymphocyte count will be low, and the NLR ratio, that means the neutrophil lymphocyte ratio, will be increased. Because the lymphocyte count is low, this ratio gets increased in children with COVID. And there will be high inflammatory markers. That is, your ESR will be high, your CRP will be high, your serum ferritin levels will be high, and also your D-dimer levels will be very much high. And coming on to a chest X-ray, so you do chest X-ray only in those patients presenting with mild to moderate symptoms and not in asymptomatic patients. So whenever you have a child with COVID, suspected COVID, you do a chest X-ray, you will be able to see this bilateral haziness or your ground glass opacities. So this is very characteristic in your COVID patients. So especially in your peripheral lung field, you'll be able to appreciate this ground glass. That is a glass which has been rubbed with. So that is meant for your ground glass appearance. So you'll be able to see a haziness in your bilateral lower lung fields. That is characteristic in your COVID patients. And CT chest is actually not necessary. Most of the children can be diagnosed from an X-ray. If at all it's not visible in an X-ray, then you go for a CT chest. And echocardiography, as I already told, child might present with Kawasaki-like syndrome. Then you do an echocardiography to detect the aneurysm size, whether they're going to be having coronary aneurysm or not. So for which you need a echocardiography. So I think it's very clear to everyone. And so thank you one and all. So I'd like to thank Principal Dr. Shakuntala ma'am, and I would like to thank Dr. Karthika. Actually, I and Dr. Karthika, we did our school together. Actually, we both were batchmates in school in Chennai Vidyashram. And I would like to thank the medicine department for giving me this opportunity to share our knowledge with all the students and faculties. So thank you very much. And now I think if you have any questions, we can go with the questions. Thank you very much.
Yes, students. If you have any questions, kindly post it in chat box. I will read to doctor for your answer. If you have any questions, post it in. Students, enough said, sir. Kindly, if you have any questions, you can post it in chat box. Okay. Doctor, for example, I'm sure that our students have a clear outlook. I think there is no. They are all are interested in your presentation. Everyone will tag on your presentation. Okay.
Okay, sir.
And now I inviting our Vice Principal, Dr. Brito sir, for a special address for this session. Sir.
Good evening. Yeah. Good evening, all. So wonderful presentation, very informative. Dr. Manoj Kumar was keep on stressing about the observation. What observation we have to make? It's not only with the symptom, each and one. When you are taking, when you are receiving the symptom, when you are examining, when you are doing the investigation, everywhere the observation is very, very important. So the examination or history taking, yes, the history what we are getting from the mother, sometimes it will be misinterpreted. Yes, the mother will because of the anxiety, she may say something, she may exaggerate and she may. So one example I can say, sir was saying, Dr. Manoj Kumar was saying about the asthma. When the child is there in the lobby, you just see, ask the child to walk. Whether it is psychogenic or it's a real problem. So that is observation. So everywhere the observation is very, very important. That is very much stressed right from the history, examination and investigation. And we can say like the symptoms, whether it's a cider or wheeze, cough. So there also how to differentiate, how to narrow down the diagnosis. Really it is very, very informative, sir. Thank you so much on behalf of Venkateswara Medical College and Hospital Management and the Practice Medicine Department and all the faculties, all the students. Thank you so much. Thank you, sir.
Thank you.
Thank
Thank you, everyone.
Okay. Thank you so much, sir. So now this is our time to introduce our sir, Dr. Rajendra Prasad sir, HOD, Practice of Medicine Department. For past 15 years, his guidance and hard work is impressive. He is a good diagnostic person, dynamic person actually. He is here to deal with a topic, homeopathic approach in pediatric respiratory disease. On behalf of management and Department of Practice of Medicine, I once again welcome. Now I request to Dr. Rajendra sir to take over the section. Sir, please.
Good afternoon. Is my voice is audible to all? Please
yes, sir. It's audible.
Yes. Okay. Fine. Very good afternoon. It's a wonderful session which I was attending with Dr. Manoj Kumar. It's a very wonderful session, Dr. Manoj Kumar. Thank you for providing this lot of informative for our children. And I also wanted to thank our principal, correspondent, and all, vice principal, sir, and all the staffs who are making this webinar as a successful as of now. And today we're going to talk about, we have already so far doctor has discussed, doctor has already explained how we need to diagnose a condition, how we need to approach, how we need to approach for a pediatric case, how we, as a physician, as a doctor, how we need to approach for a pediatric, especially for a pediatric cases. So now here we have come here to talk about two things to say about some differences which we actually plan for. Before we go into this wonderful, another next session too, I just wanted to highlight certain points which is very important, which is very motivating for me during my days of studies in homeopathy. See, one is which is more impressive. The fear of the Lord is the beginning of knowledge. So this verse is selected, taken from Bible, Proverbs 1:17. The fear of God is the beginning of knowledge. Here, as a physician, the knowledge should come from God, not from anything else. But now, as I usually, most of the time I used to say this word to everyone: only when your mind knows, your eyes can see. Only when your mind, like whatever you learn, whatever we read, whatever we observe, whatever we see, that should be registered in our mind. When your mind doesn't know what you are observing for, what you are observing, what you are looking at, what you are actually thinking about, when you attend a case as a physician, as a doctor, it is very difficult to acquire the knowledge of particular situation, because the homeopathic approach towards this condition especially is very important. It's very challenging, to be frank. Of course, I also underwent a lot of challenges to go through and get this experience of learning homeopathy. To be frank, homeopathy is not something different. It is not something, a method. It's a different method of treating disease. It is something like a metamorphism. We normally, I think many of you should have known what is the meaning for metamorphism. The metamorphism is nothing but it is transformation from one level to other level, to one situation to other situation. That is called metamorphism. So one that gets transformed. For example, when we read in a science, lava is being transformed to other organisms. So this lava formation and to the next level, it's another important. Now we're going to talk, before we are going to enter into this topic, metamorphism of a physician. We need to read. We need to think about what is the metamorphism. What made this homeopathy to come? What is the metamorphism of a physician? It is none other Dr. Frederick Samuel Hahnemann. He was an allopathy doctor, was well known, where he's a well practiced, but he was not satisfied with what actually it is trained for and he is practicing for. So what he actually did, what he has actually done, he found out something is not actually working out what he is actually going for. So this situation made a point, which made up his mind to find an alternative method of treatment in giving good clinical efficiency. Because I'm very sorry, Dr. Manoj Kumar, because this is some transformation which I need to talk about it, because wherever the people goes, the people should get cured. That is, the knowledge of health should be there with everyone. The approach, I'm not here to say the approach is something totally different from allopathy. No, I'm not against for that. But the modern system teaches us how to diagnose a condition, how to diagnose a condition of treatment, to handle this particular system is concerned. Because the learning is the foremost important in our situation, in our life, and as a physician, we homeopathic doctors are not different from the other system of medicine. All are called as doctors, because people bring to us, in some situation, like do something to bring our children, to do something to get our child back to life. So They don't think about whether it is homeopathy or it is allopathy or it is some other system of treatment. They want the approaches as what brings a physician, what brings a patient or person towards a physician is important. What brought the person to a physician is probably important here. Now, what is studying a physician? For example, what I just say in the respiratory system, when we observe people, when we observe some, when we or thing has happened, we have to do immediate tracheostomy. We need to create air ventilation to make the person to breathe. It is an emergency technique of emergency technique which to open the air pathway if some injuries having the upper respiratory system. We have to accept it. Some systems will have to should be adapted in order to help the person to breathe. But now, here in homeopathy is concerned, the approach, here we always look into the approach factor. I just wanted to share your my PowerPoint, but I'm finding it difficult. I don't know what is the problem here. I'm finding it difficult to share. My PowerPoint is displayable, and I'm not sure. My voice is audible again?
Sir, your voice is audible, but presentation is not there. Your PPT is not visible.
Yes, okay, fine. Okay, I will just try to display it because it is not opening up. It's not sharing it to the. Okay, anyway, let it take its own. So before I just want to convey the matter, like for example, as a physician, as a doctor, as a student, students of homeopathic medicine, studying homeopathy, we have to make sure this knowledge of health, the knowledge of health is very important for us. To learn, to know the knowledge, to acquire the knowledge from first year to final year, the system is already divided into various levels. To know the knowledge, anatomy and physiology and biochemistry, knowledge of these three subjects is very important. As a physician, as a person, how this normal, the structure is supposed to be, how a normal person should be, how a normal physiology should be. This needs to be evaluated and this need to be observed, and that is what Dr. Manoj Kumar was explaining it very neatly, and he was explaining it very wonderfully. And this is very important. To be a physician, we need to diagnose what's the problem, what the person is going through, whether the person is normal or abnormal. If he is normal, and what brings him, whether he is structurally normal but functionally he is finding some problem, he is facing some difficulties. In that sense, so we have to think again, and see what brings the patient, what brings the person to us. So now knowledge about the health is very important in order to have a good approach of to have a good to approach homeopathy, because knowledge about health. So as a physician, all homeopathic system or homeopathic method of treatment will not vary with any other system. Though we look into the symptom similarity, but we have to think about what actually this topic is. My thing is audible. PowerPoint is visible. Again, it is displaying here. That's why I asked. Is it visible?
Sir, your presentation is not visible, sir. Your voice also not clear.
Yeah, but it is okay now? Is it okay now?
Yeah, now it's okay.
Okay.
Your PPT is not visible,
here the presentation is open. The presentation is open here.
Yeah, now it is visible. Your presentation is visible, sir.
My presentation is there.
Hello? Your PPT is visible, sir. You can continue.
Okay, fine. Thank you so much. Fine. Just a few minutes. Yeah. So I think it is visible now.
Yeah, your screen sharing is active, sir, but still your PPT is not visible. Your screen sharing is okay.
Fine. Okay. Let it take its own time. No issues. Just go with the waste time which we have already spent much of our time. Now, so I think now it is visible. I think. Am I right?
Still your screen is there, but no PPT. What is there displaying is selected item to share.
Okay, fine. Let me think about it. So let it take its own time. No issues. Fine. Now the point I left here is the approach of the homeopathic treatment. The approach towards an approach. We go towards the approach of taking. Handling this case. The knowledge about health is very important. The knowledge of health. So the students who are attending from first year to final year, I request you to have a good knowledge, to learn a good knowledge of the anatomy and physiology is very important. And secondly, in that is also very important. And secondly, the knowledge about the disease. According to aphorism, physicians should know the manifestation of disease. So the manifestation, according to aphorism 6 and 7, the manifestation of disease should be learned properly. So that is the manifestation where we learn is from pathology and microbiology. So this manifestation helps us to understand what actually we are going through. In the person through. We should have an affair. We should learn. We should also have the knowledge. We should also have a knowledge about what actually the knowledge about the remedies. The remedial knowledge is very important here. There is some difference in pharmacology, and homeopathy. Method of treatment was yes, method of treatment. Method of case because we give importance on our life space. In case of children, we always have to look what child should be in future. We should always have to look, should also have a knowledge about the normal understanding, about the normal situation, about the normal condition of the after 15 or 25 years, the child should become. So this knowledge is very important in this case here. And for that we are reading organon of and materia medica, which is the essential topic which we are reading. And in case, good case taking is an art. To be frank, good case taking is an art. Dr. Manoj already has explained us the importance of case taking, because 75% above will be based on the good case taking. So this is a physical problem, environmental problem, or because of the social problem, or because of any other reason. The physical approach the development is very important for a child, because on observation, as we all know, we need to be an eye observer. As a physician, we need to have good observation in case of pediatrics. We should be able to adapt it when a child is normal. When a child is waiting with the parents in your waiting room, and the behavior of the child be observed, and the behavior of the parenting should be observed, and the attitude of the parents need to be observed. These are all very important in case of homeopathy is concerned. So the knowledge about case taking, the method of case taking is equally important for a good approach towards the homeopathy. What is the meaning for approach? The meaning for approach is that is come closer. The something is coming closer. So there the homeopathic approach, we need to go a little bit closer. It is not a normal approach. It should be a little bit closer. We need to keep observe from the day of from the day of the pregnancy for the child. We should, it is very important to understand to us the mother what is the mental state when she was carrying the child. The mental state is very important. The mind state is very important while she was carrying the child in that situation. So the formation of the womb, the child inside the womb, the various situations, various conditions that we used to call in homeopathy, we used to call it as a miasm, the seat of disease, where the miasm stands for where the actually the situations is going. So this is very important. I'm very sorry, like I'm not very sure the presentation is being displayed or not, because this time is running very short, so I need to hurry up. So I'm very sorry, but still I'm just working on it to get your display on, because it will be more important.
Sir, your PPT is in
okay,
half
fine.
screen.
Now
I think your internet
full screen
is not. I think your internet connection is poor, because voice
my
also
voice is
breaking. No, voice also not much clear.
Just a minute. Just a minute. I'll just correct it now.
Dr. Sendil sir, anything we can do?
My voice is audible? Hello.
Yeah, audible, sir.
Okay. Is it clear now? Voice is clear?
Yeah, your voice is clear, sir.
Yes, I'm trying to share the PPT.
Hello.
Hello, Sendil sir.
Yes, sir.
Sir, anything we can do?
Sir, kindly turn off your video, sir. Just turn on your audio only, and also the PPT also, sir. Kindly share your PPT. Turn off your video.
Okay. Okay, I need to turn off my video. Okay, fine.
Audio மட்டும் இருக்கட்டும், sir.
Okay, till it gets connected, Let me continue for some time. Approach towards the pediatric age group. Now, the definition or the understanding for approach is something we need to get closer towards this current age group, because they may be expressive and they may not be expressive, and this depends upon the person, and depends upon the individual of the child and how it has been brought up. As we all know, and we supposed to know what we mean a term called miasm. Miasm, which has too many things, and in that sora, psychotic, syphilitic, and the last is tubercular. And the soric child is the healthiest child. So when we observe, when we see a child patient, we have to elucidate whether this child is healthy or not. On looking at the facial expression, the good soric child will be, will be influensive. The good child will be influensive, and it will try to influence the atmosphere, and the good soric child will always try to attract other people, and the other people will start admiring the soric child. So we have to think, we have to get all these things in mind, that the effort which we put to understand a child, to observe the pediatric case, we have to think whether the child is in soric phase, if not in psychotic phase or syphilitic phase. The last is tuberculinum, that is in both the extremes. With both extremes will be the other either in the soric phase or in the other side. Fine. So this is how we need to observe. We need to start observing the child actually. So when we start observing the child, as the case was already explained, the details was already explained, how to meet out, how to handle the child is very important here. How to handle, how to take the cases. While taking the cases, what are all the information is required to handle is very important, which we equally we observe, and which we equally look into this matter is concerned, because the pediatric case is very sensitive. It is not that easy how we handle adult cases, adult issues. Here, pediatric, especially in respiratory disorder, the child will be suffering with some conditions of difficulty in breathing. For example, in respiratory concern, what brings the child towards a physician? As we have already said, the child might be having some kind of respiratory disturbances. For example, any discharges or any of or the child may develop a fever or recurrent cold and cough, all the upper respiratory inflammations. So in case we always understand the cough, sneeze and discharges for a child are not to be considered as a disease. It is something like it is a reflex symptom. It is a reflex system which is trying to expelling it out the foreign particles which has been deposited inside. Because the child, if the child or a person is suffering with a cough is a symptom, not a disease, or discharges from the nose is not it's a symptom, it's not a disease, and sneezing is a symptom, it's not a disease. But if it is continuous in the lifestyle and it is bothering their routine life and the routine lifestyle, it is called creating a problem where the person was not able to function normally. Then that brings the person possessed. When the person was not able to function normally, for example, in case of asthma in children, we have to think most of the parents will complain, my child is not regular to the school. There is continuous absenteeism in the school. The children was not able to attend the school regularly because the school days, because whenever they get they are getting breathlessness or breathing or wheezing kind of, and often suffered with cough and wheezing. And many of the parents don't like or doesn't like whether the child is having asthma. If we label it under asthma, many of the parents won't be willing to accept it, because they will say the wheezing is there, but they don't accept it is as an asthma at the initial stage. But it is our responsibility to make them to understand whether the child is able to do the physical activity properly or not. The child is able to function normally or not. The child has suffered with any disease. The past history of the child is very important to ask about whether the child has suffered with any disease or not. It should be taken care. And in the child and the breathing observe the breathing, the chest or appearance is very important. Mortality, we used to say during in night or during in the or during in the morning, early morning, or during anxiety in the child. The fear is also one of the reasons for breathing difficulties. And the exposure to tobacco, for example, what is the question here? Exposure to tobacco. How come the child will get exposed to the tobacco? It's simple. It's just surroundings. We need to evaluate the surroundings. Is there any of the parents are smoking, having a habit of smoking? These symptoms will cause the child to suffer with in the later during the developmental days, or some kind of respiratory allergies will be there. See, generally, I used to advise to every parent, it's like the child need to function normal, child need to behave normal, and the child need to breathe normal in spite of whatever the situation is. So if the child is not able to respirate normal, but the child is finding some difficulty, and it needs to be brought to the notice of a physician to evaluate clinically. Clinical evaluation is very important here to identify what actually the child is suffering with. The clinical evaluation is very important here, because without the clinical evaluation, the clinical evaluation need to be confirmed with laboratory investigation or imaging, X-rays and laboratory investigations to understand whether any allergic manifestations going on, or developmental allergy, or immunoglobulin E levels should be evaluated. Is there any histamine levels in the blood should be evaluated. This will help us to identify whether the person is going for. Always I used to say evaluation, the clinical observation, the clinical importance is very important. The clinical, how the child is suffering, how the child is going through it is very important. How level of clinical evaluation. The physician should be able to read, be able to mark it out clinical evaluation, and that is confirmed with the laboratory investigation. This is a part which we as a physician. So there is no difference between homeopathy and other system of medicine. The homeopath should diagnose the case. Without diagnosing the case, without diagnosing the condition, it is very difficult. I'm not saying it is very difficult. It is not good to prescribe medicine. Actually, it is only palliating the situation. Because in active prescription, we can only palliate the condition. We can only bring some kind of better healing for the acute reason, but that there may be a chronic ailment. The person should have a seat of chronic ailment. That how we can understand, how we can elucidate that chronic child may suffer. Family history will give us the information. There is going to be a genetic backup. The genetic problem is also going forth. So this is very important to understand. This is very important to evaluate the condition as well in case of respiratory concern. And after diagnosing and we have to put the knowledge of homeopathy, which that is called knowledge of remedies which we acquired in homeopathy. that is the knowledge of materia medica is helping us to evaluate the symptom, to manage the symptom, to analyze the symptom. That is disease diagnosis, that is the collecting of symptoms based on the disease. As we already always focus on constitutional remedy, constitutional actually to be recorded. But now here in this seminar, we are just talking about respiratory disorders. How do we going to approach the respiratory disorders? There are some remedial approach which we can go with the repertory part, to be frank, because the repertory part is very important. Repertorization is very important in this case. Before we go with the repertorization, we have to divide the case, we have to analyze the miasmatic approach towards this case. What you are actually trying for, what we are actually trying with, what we are actually looking for is very important in this condition is concerned. Because without having a clear pathway, without having a clear destination, it is very pathetic to treat the case in homeopathy, because the homeopathic medicines doesn't have any side effects, but in my experience, it just has a very harmful effects equally with the like the other system also, when we do not prescribe it in proper manner. So the prescription matters here. How are we going to prescribe this treatment? How are we going to handle this condition is also important. And the reaction with the child is important here. The genetic pattern, environmental influences. When we handle a person, when we handle a child, hereditary, as I already said, hereditary, genetic pattern, environmental influences that one experience in the early stage of one's life. See how the child is, involving in the environment, how the child is behaving is very important. Understanding the child and its behavioral pattern, which will help us to give underlying the miasmatic, which will help us to determine the miasmatic approach of the condition. Now, so just to read about the miasmatic condition, to talk about the miasmatic influences, see the child we need to evaluate. For example, how a normal child is supposed to be, how a normal child need to be. That is the knowledge about the normal human being, normal healthy person is very important. As in the organon, we always read about the cure, restoration to health. So what we mean by health? Health is something like we need to bring the equilibrium state. The person should have all states level of for example, physical, mental, and social well-being should be equally balanced. The child should be able to get balance to be in the condition. So this is very important to understand this healthy system. To understand, we also look into the normal system of or normal subjects. Knowledge about the condition is very important. Now, after acquiring all this information, after acquiring all these details, and now what we actually is looking, what we need to look for is repertorization repertorization is very important, which of many of our leaders, many of our eminent physicians talked about how to repertorize the case is very important. According to Kent's method, we need to start with the mental and physical, mental general, physical general, and peculiar rare symptom and particulars, and all other things should be kept in the order to analyze and to derive the prescription what we are meant for. Because in approaching towards the pediatric cases concerned, though we read, though we observe, though we see clinically in various levels, various methods we adapt, the point which we need to keep it in mind, we need to restore the sick to health. So identify we need to identify the sick condition, the sick the condition brought to a physician, and the method of homeopathy, the medicines which we choose, the repetition of the doses, and the medicines which we help, which will always selection of remedy is very important. This selection we always will be done with the method of repertorization. So repertorization is foremost important to complete the prescription of homeopathy. Without repertorization, it is even whatever it is. In the practice of medicine, though we are conducting this webinar where in the Department of Practice of Medicine, the practice of medicine helps us, the medicine system helps us to diagnose the condition and evaluate the condition, rule out the other differential diagnosis with the symptom similarities, and with that knowledge, we have to go into a homeopathic system of prescription. Homeopathic system of prescription has certain protocols to be followed. In pediatric concern, miasmatic background should be analyzed properly, and the observation with the parent is very important. And after analyzing that, selection of, what is like analyzing the symptoms is equally important. After analyzing, and the repertorization should be done based on the whatever the method which is we normally we used to do it in Kentanian method of repertorization. There are various other system methods of repertorization, but depends on the country. Now, repertorization of asthma. I just took about certain conditions of respiratory system. When we take it asthmatic, difficulty from dust or any dust exposure, or difficult on exertion, or wheezing. When I just observe, when I start repertorizing this condition, what actually happened? So we got some highlighted remedies. The first two remedies, arsenic amalgam, and the second one is Atypical, that is arsenic amalgam. I just selected only 4 symptoms. That is respiration, respiration asthmatic, respiration difficult, dust as from respiration difficult, exertion after, and the last one is wheezing. So these are the four symptoms I have taken to repertorize this condition. It is a generalized, it is not specific, it is generalized. When I have taken this generalized, I got 2 symptoms, I got 2 remedies, along with the other 2, one is calcarea carb and calicarb. So these are the 2. But now it is not very important that we need to set only ourselves to be prescribed, or Atypical to be prescribed, or calicarb to be prescribed. Once we derive some derivation, or then put the knowledge of materia medica here. Knowledge of materia medica will help us which level of the condition, which stage the child is going through. Whether the child is already influenced with allopathic treatment, or it is not associated with any other treatment or fresh. If it is associated with, already influenced with allopathic treatment, then miasmatic role plays here. So the miasmatic prescription should be initiated, and prescription should be in the form of the first prescription should be should help the patient to come out of the present complaint what the complaint is brought to a physician. Only based on that, and the rapport between the parents and the rapport between the child is very important. The child should be able to should have a comfortable understanding with what actually it is going for. I'm very sorry again because the presentation was not very clear to you, but still I just wanted to tell you approach of towards homeopathic approach. We have to put all the levels: knowledge about the health, knowledge about the disease, and the knowledge about the remedies. This is important here. So what health talks about how a child should be healthy from the development to the the stages of childhood should be observed, and disease, what is the level of infection and prognosis of the disease should be, manifestation of the disease should be known, and finally remedies, what is the remedial approach, what we are trying to restore the health, or to identify the derangement of mental force, or where it needs to be, should be evaluated. So putting the knowledge to all final years or CRI or the other doctors, to whoever, we generally advise is the approach always it is something specific. The primary important is diagnose the case. We need to diagnose the case. without diagnosing the case, without writing diagnosis in our case sheet or in our any of the condition. It is very poor. It is very difficult to help the person to come out of the state of care. So I suggest once again, I don't want to take much of time since the presentation was also not very clear. I thank you one and all. I thank you once again. I thank Principal Madam and Vice Principal Sir and other our college managing authorities. I thank for the department persons. I'm Dr. Job, Dr. Nitya, and I thank each one of you for giving this short duration presentation to give an input, to give a conclusion of what a homeopathy, how a homeopathy is different, what the method and approach of homeopathy is differs from in taking cases, in handling respiratory disorders. There's a lot of things to be learned, and we need to keep on learning. The last and finally, I want to emphasize and say, only when our mind knows, our eyes can see. So please, I request all students, use the precious moment in your life. Use the precious learning moment in your life. When you are in a first year and when you are in a second year, please acquire the knowledge of health and the knowledge of disease. And when you come to the third year and final year, and we're going to start applying, the training will be there, the way of applying your knowledge about the find a remedy for a physical condition. In case of pediatric concern, you need to have a lot of observation. So this is a humble request from my side. Based on the Department of Medicine is concerned. So this is very important. I thank you one and all. I thank you once again. I thank each one of you for providing this wonderful seminar and to have a conclusion about it. Thank you, sir.
Sir, that was a refreshing section. Even PPT is not visible. We all learn a lot from your presentation. I am sure the students benefit from your knowledge you shared. Thank you, sir. I request Dr. Brito, sir, for a special address for this section. Sir. Brito, sir. Hello, Dr. Sindil, sir.
Yes, sir. Brito sir is not there, sir. I'm just calling him.
Okay. Can I call Nitya ma'am to give out of thanks? See, students, if you have any questions, kindly post it in the chat box. Students, if you have any questions, kindly post it in chat box.
Hello.
Hello. Sir, you are audible, sir.
Yes, good, yeah.
Okay.
Now?
Yeah, it's audible, sir. You can give your
Okay, ma'am?
address. Yeah.
Okay. Once again, good evening to all. Again, so one more wonderful presentation from Pediatric Department of the Practice of Medicine. Dr. Rajendra Prasad sir, he is touching upon the mathematic aspect also. How that historic presentation and each presentation, how it is correlating with the maths and the pediatric stage, how to select the remedy. So it's very clear. It was very informative for the students, but regularly he is teaching, and moreover, this is such particular point he is touching upon this pediatric aspect. It was very nice, and it was an excellent presentation. I thank our speaker, Dr. Rajendra Prasad, and I thank our management, managing professor, Engineer has given this wonderful opportunity. And all that the backbone is our principal madam, Dr. Sadala madam, who is the one said, no, each department wise, so why can't we have a webinar? So, madam, we'll start with the clinical side. So, we started with the practice of medicine. So, madam, so continuous engagement and our trustee member, Madam Padmanabhan madam, all these people and Dr. Kartika madam, everyone's encouragement and continuous support, we are able to conduct continuous webinars. I thank our principal madam, our trustee member, Padmanabhan madam, and Dr. Kartika madam. And I thank all the faculty members who are involved in this kind of these activities, and especially the practice of medicine department. The practice of medicine madam has taken this particular task, especially in pediatric age group, that how homeopathy is working out, how this particular aspect. We have the other side, especially the other system of medicine. You know, they go in very deep. Okay, they get good number of cases. That we learn a lot when a good number of cases are there, and various signs, all these things that Dr. Manoj showed. That also we are able to get this through our management. So for that we thank, and at the same time, when you take any topic, any clinical topic or any topic, always know we have to finish with the homeopathy part. That was very much stressed from Dr. Rajendra Prasad. So that was also really good. So that aspect of the practice of medicine people, they arranged. I thank Dr. Rajendra Prasad and coordinating with the practice of medicine department and madam, Dr. Saijal Jobu. He has done his good work and his NQ work and all that arrangements he has done. And the other persons is always the behind the scene, Dr. Kumar always there. The technical issue, anything is there, or whatever may be, or the arrangement, communicating with the speaker, communicating with the management, and system arrangement, everything. And assisting other Dr. Kumar here also. Involved in this, I thank Dr. Kumaran and Dr. Kumar this particular occasion, and I thank all the students. Today the participants are very good number of participants today. Okay, really you have learned a lot. I feel here patient in the pediatric age group. Okay, I thank everyone. All the
Thank you, sir. Now I invite Dr. Nitya for vote of thanks. Dr. Nitya? Dr. Nitya? Are you there?
Am I audible?
Audible.
Sir, am I audible, sir? Jobu, sir, am
Yes,
I audible?
yes, you are
Oh.
audible.
Okay. Good evening, one and all present here. It's my privilege to have been asked to propose a vote of thanks on behalf of Venkateswara Homeopathy Medical College and Hospital. Our Honorable Founder, Shri Armugam Sir, respected Principal and Correspondent, Dr. Shakuntala Ma'am, Managing Trustee, Engineer Shiva Subramaniam Sir, Trustee Members, Dr. Karthika Ma'am, Dr. Batmavati Ma'am, our beloved Vice Principal, Vito Wilbert Das Sir. On behalf of let me call it fraternity of medical era. Yes, together on my behalf, extend a very hearty vote of thanks to all speakers for gracing your knowledge of pediatric approach of respiratory disorder, sharing us your findings and opinions today. I must mention a deep sense of appreciation for Dr. M.Manoj Kumar sir for his explanation about approach to common pediatric disorder, history taking, examination and clinical approach to the pulmonary respiratory pediatric respiratory disorder. As in our homeopathic system of medicine, we are a very good scope in case of the pediatric disorders. So it is very helpful for us, sir. Further, we are grateful to the speakers, Professor Dr. Rajendra Prasad sir, HOD and Department of Practice of Medicine, for sharing us holistic approach towards the respiratory disorder in pediatric age group people. Even though it is a technical problem, we understood, sir, how to treat the pediatric age group people as a holistic approach. Thank you, sir. We are all inspired by your gratitude, great words, sir. Founder, once again, Founder Shri V.K. Armugam sir, Managing Trustee E.R. Shiva Subramaniam sir, Principal and Correspondent ma'am, Dr. Shakuntala ma'am, Vice Principal Dr. Brito Wilbert Das sir, our colleagues, academic coordinators, CRRI, students. Once again, I want to state that we are all most grateful to all the speakers on this webinar. We thank you for being with us this evening. It's been a great pleasure. Thank you very much, sir.
Thank you. Thank you, Dr. Nitya ma'am. Okay. So this is the end of the session. Thank you all.
You want to update that form?
Yeah, all students complete the feedback form within an hour. After an hour, you cannot able to accept that. Dr. Sendil sir will compare with your attendance and your feedback form. Then only you get your e-certificate. So update your feedback form immediately. Thank you so much.
Thank you. Thank you.
Thanks.